Welcome back to the Reimagine Healthcare podcast. I'm your host, Noah Volz, coming to you from Phoenix, Oregon. Today, we're going to talk about something you don't see very often anymore in American healthcare. A healthcare organization that's actually owned by the doctors and nurse practitioners who work there. While the rest of the country seems to be racing toward bigger hospital systems and corporate consolidation, AllCare Health is doing something different, and the results are pretty interesting. AllCare Health serves about 70,000 people spread across 4 counties in southern Oregon: Jackson, Josephine, Curry, and the southern part of Douglas County. It's a rural area which comes with its own healthcare challenges, but here's what makes AllCare different. It's owned by nearly 50 physicians and nurse practitioners who actually practice medicine in that same region. These aren't investors sitting in New York or Los Angeles. These are people who see patients every day in the communities where AllCare operates. And this ownership structure isn't just a nice detail on paper. It actually changes how decisions get made. When AllCare generates surplus revenue, and we're talking about an organization with $472 million in annual revenue, that money doesn't go to distant shareholders. Instead, it gets reinvested right back into the community. We're talking about things like housing for people awaiting addiction treatment, transportation services to help people get to appointments, and programs that make healthcare accessible in different languages. What I want to explore today is how this physician-owned model creates fundamentally different incentives and why those incentives matter for everyone in Southern Oregon, whether you're an AllCare member or not. To understand why this matters, it helps to look at the landscape of healthcare ownership in America. There are really 3 dominant models right now. First, you've got for-profit corporations. Their primary obligation is to shareholders, maximizing returns, hitting quarterly targets, that kind of thing. Here in Oregon, we've seen this play out dramatically with United Health Group's subsidiary Optum, which acquired Oregon Medical Group in Eugene in 2020. What followed was a cautionary tale. Dozens of physicians left the practice. Thousands of patients were told to seek care elsewhere, and the focus shifted to what departing doctors described as money, efficiencies, and quotas. Legislators pointed to this acquisition as a primary reason Oregon passed some of the nation's strictest laws limiting corporate control of medical practices. Second, there's private equity. These are investment firms that buy healthcare organizations, often looking to make changes that boost profitability in the short term so they can sell at a profit down the line. Studies consistently show that when private equity takes over healthcare organizations, costs increase and patient outcomes get worse. Between 2019 and 2023, private equity investment in healthcare approached $1 trillion nationally. And third, you have large nonprofit hospital systems. Now, these are technically nonprofits, but many of them operate with growth and revenue strategies that look a lot like their for-profit counterparts. Right here in Southern Oregon, Asante is our largest healthcare provider, a community-owned nonprofit governed by a local board. While Asante maintains its nonprofit status and local governance, it still operates at a scale and with an institutional orientation that creates different dynamics than smaller, physician-owned practices. They accumulate significant reserves, compete for market share, and make decisions through large organizational structures. AllCare represents something different, a fourth model. It's a physician-owned community benefit organization where the financial interests are deliberately aligned with community health outcomes. They've actually formalized this commitment legally. AllCare is registered as an Oregon benefit company and holds B Corporation certification. For those not familiar, B Corp are companies that meet really high standards of social and environmental performance, accountability, and transparency. AllCare scored a 136.5 on the B Impact Assessment. The median score is 50.9, so they're nearly triple that benchmark. This certification means they're legally required to consider their impact on employees, patients, communities, and the environment, not just financial performance. AllCare is the only Oregon healthcare organization to have earned Best for the World recognition in governance from B-Lab, the international organization that certifies benefit corporations. It's worth stepping back and looking at the national context here, because it makes what AllCare is doing even more significant. Between 2019 and 2023, private equity investment in healthcare approached $1 trillion. That's trillion with a T. Hospital consolidation is accelerating across the country. The American Medical Association put out some striking data. In 2022, for the first time, less than half of practicing physicians own their practices. Back in 1983, that number was 76%. We're witnessing a fundamental shift in who owns and controls American healthcare, and it's moving decisively away from the people who actually provide care and toward corporate entities focused on financial extraction. The physician ownership model creates different incentives, and that matters more than you might think. When the physician owners at AllCare invest in housing stability for mental health patients, they're not just approving a budget line item, they're seeing those same patients in their practices. They witness firsthand when someone with stable housing manages their mental health condition better. When they fund transportation services, they see fewer missed appointments in their own schedules. They watch their patients with chronic diseases get better outcomes because they can actually make it to their follow-up visits. Their financial stake in the organization aligns with community health in a way that traditional corporate structures actually work against. Let me give you a concrete example. There's a patient named Carolyn from Glendale who shared her story. AllCare's proactive screening outreach caught her colon cancer early enough to save her life. Now think about that from a corporate shareholder perspective. Preventive screening programs cost money up front, and the benefits often show up years down the line. That's a tough sell when you're trying to hit this quarter's earnings targets. But physician owners understand the long-term value. They see it in saved lives, not just saved costs. AllCare takes an integrated approach that combines physical health, behavioral health, and dental care. But they don't stop there. They also pay attention to what are called social determinants of health, things like housing, transportation, nutrition, and early childhood development. This reflects something the physician owners understand deeply. Health happens outside exam rooms. A corporate model tends to focus on billable procedures because that's what drives revenue. But if you're a physician owner living in the community, you know that your patient's housing situation or their ability to buy healthy food matters just as much as what happens during their 15-minute appointment. And this brings me to something remarkable that AllCare has done. They have a senior director of housing on staff. Her name is Julie Akins, a former Ashland mayor and veteran journalist who spent months sleeping in homeless camps from Seattle to Mexico to understand what unsheltered life actually feels like. Think about that for a moment. A healthcare organization employing someone whose full-time job is housing. That's not something you typically see, and it reflects a fundamental reimagining of what healthcare organizations are responsible for. In 2024 alone, AllCare committed over $2.2 million to housing-related investments across their service area, part of a $2.7 million overall community grant pledge. These weren't ancillary philanthropic gestures, they were strategic healthcare interventions, as deliberate and evidence-based as any medical treatment protocol. Let me walk you through where that money went, because the specifics matter. $680,000, AllCare's largest single investment, went to cover more than half the estimated cost of converting a motel into emergency housing for people awaiting detox or residential substance use disorder treatment. This addresses a critical gap in the continuum of care. When someone decides they're ready to get help for addiction, they often can't just walk into treatment that day. There are wait lists. Sometimes it's days, sometimes weeks before a bed opens up in a residential program. What happens during that wait? If the person has nowhere safe to stay, if they're back in the environment where they were using, the likelihood of them actually making it to treatment drops dramatically. Many relapse or give up entirely. This emergency housing provides a bridge, a safe place to stay while waiting for treatment placement. It's not long-term housing, but it's the difference between someone accessing treatment and someone falling back into active addiction. $200,000 went to preserving a 110-space cooperative manufactured home park in Grants Pass. When the park came on the market, residents faced potential displacement as investors made offers to redevelop the land. AllCare's investment helped residents purchase the park cooperatively, ensuring long-term housing stability for 110 families. This represents preventive health care at scale. Keeping people housed prevents the cascade of health problems that follow displacement. When families lose stable housing, chronic diseases get harder to manage, mental health deteriorates, children's educational outcomes suffer, and people end up in emergency rooms for conditions that could have been prevented. $177,500 went to Ashland School District's efforts to build and renovate housing for education workers. Now, you might be wondering what teacher housing has to do with healthcare. Here's the connection. When schools can't recruit or retain teachers due to housing costs, educational outcomes suffer. And children's educational attainment is one of the strongest predictors of adult health outcomes. The research on this is overwhelming. Education shapes lifetime health trajectories. By investing in teacher housing, AllCare is making a long-term investment in the health of the next generation. $149,000 funded a mobile team in Josephine County that provides shelter and services during summer heat waves and other crisis periods. This team meets people where they are rather than waiting for them to navigate bureaucratic systems to access help. During extreme heat, which we're seeing more of due to climate change, people experiencing homelessness face serious health risks. This mobile response prevents heat-related emergencies. AllCare also partnered with Jackson Care Connect, United Way, and the City of Talent to invest in Oro Vista Village, 26 duplex apartments for low-income seniors in Talent. The project went from groundbreaking to occupancy in just 8 months using modular construction. The first resident was a man who had been sleeping in his car. That's the human reality behind these investments. Real people moving from cars and tents into stable housing. These investments share common characteristics. They create permanent infrastructure rather than temporary assistance. They serve diverse populations across the housing stability spectrum, from people sleeping rough to teachers priced out of the community. And they leverage partnerships to multiply impact. AllCare's dollars catalyze additional funding from other sources, so the total community benefit exceeds what any single organization could achieve alone. Now, you might be asking, why is a healthcare organization investing in housing at all? Isn't that the responsibility of housing authorities or social service agencies? This is where we need to talk about the research on housing and health because it's compelling. People experiencing homelessness die an average of 12 years earlier than housed individuals. They have dramatically elevated rates of chronic disease, infectious disease, mental health conditions, and substance use disorders. Emergency departments become their primary care providers at enormous cost to both individuals and communities. According to AllCare's own analysis, a chronically homeless person costs taxpayers an average of $35,578 annually, primarily through emergency room visits, hospitalizations, law enforcement interactions, and crisis interventions that could be prevented with stable housing. But housing instability isn't just a problem for people sleeping in tents or cars. It affects working families barely holding on, seniors on fixed incomes choosing between rent and medications, and people one medical emergency or job loss away from losing their homes. In Jackson and Josephine counties, over 30% of renters spend more than 30% of their household income on housing. Economists consider this threshold cost-burdened. When housing consumes that much of a family budget, everything else becomes precarious. Healthcare becomes optional. Prescription medications go unfilled. Preventive care gets postponed. Chronic conditions deteriorate until they require expensive emergency intervention. Your zip code predicts your health outcomes better than your genetic code. Whether you have stable housing affects your health as much as whether you have access to a doctor. AllCare's housing investments reflect an evidence-based approach called Housing First, which prioritizes getting people housed before addressing other needs. Traditional homeless services often require sobriety, mental health treatment participation, or employment before providing housing. This creates a paradox. People must demonstrate stability to qualify for the very thing that would make stability possible. Housing first reverses this logic. Provide housing first, then address health and social needs from a position of stability. Research consistently shows this approach works better clinically and costs less financially. AllCare's structure makes this kind of long-term strategic thinking possible. As a physician-owned, community-governed, coordinated care organization, they're not beholden to distant stockholders demanding quarterly profit growth. They're accountable to the communities they serve. This is the same CCO model we talked about in our Jackson Care Connect episode. Oregon's innovative approach to Medicaid, where organizations receive capitated payments, a fixed amount per member per month to cover all healthcare needs, rather than fee-for-service payment. This fundamentally changes the incentive structure. If you get paid the same amount, whether someone needs expensive emergency care or stays healthy with prevention and primary care, you're incentivized to invest in keeping people healthy. You're incentivized to address the upstream factors that create disease before they become expensive downstream crises. Traditional healthcare systems know that social factors like housing affect health outcomes, but their structure doesn't allow them to act on it. If you're a for-profit insurance company maximizing shareholder returns, you can't justify spending money on housing. It's not a billable medical service. But if you're a CCO with a capitated budget and a mission to improve community health, investing in housing isn't just ethical, it's financially smart and mission-aligned. AllCare runs other programs that demonstrate this community-focused approach. Ready Ride helps people get to medical appointments, addressing the transportation barrier that causes so many missed appointments and delayed care. The Babe Store provides supplies and support for new parents. These aren't the kinds of initiatives that typically get greenlit in boardrooms focused on maximizing billable procedures, but they're exactly what communities need. AllCare maintains a network of over 1,500 local specialists and hospitals. And here's a key detail. They support these independent providers rather than acquiring them. That's pretty countercultural in today's healthcare environment, where the trend is toward buying up smaller practices and bringing everything under one corporate umbrella. AllCare's approach preserves local control and independence while ensuring coordination and quality. Here's an interesting detail that speaks to AllCare's workplace culture. They've been recognized as a top workplace in Oregon for 4 consecutive years. In rural areas, recruiting and retaining healthcare professionals is genuinely challenging. People have options. They can go work in cities where there are more amenities, more colleagues, often higher pay. Christine Senhauser, AllCare's Chief Operating Officer, put it pretty plainly. Survival in rural healthcare requires creating an environment where skilled professionals actually want to stay. When your mission is centered on community benefit rather than shareholder returns, that becomes a competitive advantage. It attracts people who went into healthcare because they wanted to help people, not maximize billing codes. The long-term implications of AllCare's approach extend beyond individual projects. The emergency housing created through the motel conversion, the preserved manufactured home park, the senior housing and talent. These are permanent assets that will serve community members for decades. Unlike emergency assistance that helps one person one time, infrastructure investments serve multiple generations. AllCare's investments also leverage additional funding from state sources, local governments, and other philanthropic organizations. This multiplication effect means AllCare's $2.2 million investment catalyzes significantly more total development. Every successful housing project also demonstrates feasibility. The 8-month timeline for Oro Vista Village Senior Housing and Talent using modular construction shows that rapid development is possible. Other communities can study and replicate this approach. Julie Atkins participates in statewide housing policy discussions with the Oregon Health Authority and other stakeholders. AllCare has urged legislators to make rezoning rural Oregon a top priority, recognizing that regulatory barriers slow housing development. This policy advocacy amplifies the impact of direct investments. The 2024 Community Health Improvement Plan was jointly developed by AllCare, Jackson Care Connect, and Jackson and Josephine County Public Health Departments. This collaborative planning identified housing as one of 4 core priorities through 2029, alongside healthcare access, behavioral health, and community building. When multiple major funders coordinate around housing, communities can plan comprehensively rather than patching gaps piecemeal. Atkins' research documenting lived experiences of homelessness through hundreds of interviews, captured in her report, Finding Home, A True Story of Life Outside, provides qualitative data that complements quantitative housing statistics. Her journalism background brings storytelling to policy analysis, making abstract housing statistics personal and urgent. Now let me talk about where AllCare's model could be even stronger, because I think it's important to look at this with clear eyes. Systematically tracking health outcomes for AllCare members before and after receiving housing support would build the evidence base for housing as healthcare. Publishing data on emergency department visit reductions, hospitalization rates, chronic disease management improvements, and healthcare cost savings would help other CCOs and healthcare organizations adopt similar models. Right now, we know conceptually that housing improves health, but having AllCare's specific data would make the case even more compelling. Most current housing investments address emergency housing or homeless services. Expanding investment in workforce housing and rent assistance for people at risk of losing housing would prevent homelessness before it occurs, likely more cost-effective than intervening after housing is lost. Following people over years rather than months would capture the full health impact of housing stability. Many health improvements from housing take time to manifest. AllCare could convene with Jackson Care Connect, county governments, and philanthropic organizations to create a regional housing trust fund with pooled resources and coordinated strategy. This could amplify impact beyond what any single organization achieves alone. So, what does AllCare's experience demonstrate? Healthcare ownership shapes incentives in fundamental ways. When physicians who see patients daily are the ones owning and governing healthcare organizations, decisions tend to align with community needs rather than distant shareholder demands. Legal structure, like that benefit company designation, enables mission-focused decisions even when they conflict with short-term profit maximization. Local control creates responsiveness to actual community needs rather than theoretical market opportunities. AllCare's housing investments embody several principles that are central to reimagining healthcare. First, upstream investment. Traditional healthcare waits for people to get sick, then treats them. AllCare invests upstream, addressing conditions that cause illness. This represents fundamental rethinking of healthcare's purpose. Second, social determinants as health determinants. AllCare recognizes that social factors, housing, food security, education, economic stability, determine health outcomes as much as medical care. Healthcare organizations that ignore these factors will never achieve meaningful population health improvement. Third, community accountability. AllCare's governance structure, physician-owned, community board-directed, benefit corporation certified, creates accountability to community health rather than just stockholder profit. This structure enables long-term thinking that traditional for-profit insurance can't replicate. Fourth, evidence-based risk. AllCare's investments aren't feel-good philanthropy disconnected from health outcomes. They're evidence-based bets that housing stability will produce better health and lower costs. This requires courage to invest outside traditional medical services, but it's grounded in research. Fifth, systems thinking. AllCare understands that housing, healthcare, education, and economic opportunity interconnect. Investing in teacher housing recognizes that educational outcomes affect long-term health. Preserving manufactured home parks recognizes that displacement causes health crises. And sixth, partnership over isolation. AllCare partners with Jackson Care Connect, county health departments, nonprofits, school districts, and housing authorities. They recognize that complex problems require collaborative solutions, not siloed interventions. So what can people do if this resonates with them? If you're choosing a health plan, you can ask about ownership models. Who actually owns and governs your healthcare organization? Where do the profits go? If you're a healthcare provider feeling pressure to sell your practice to a larger system, know that physician ownership is still an option. It's becoming rarer, but it exists, and AllCare demonstrates it can work at scale. For policymakers, there's work to be done supporting legislation that enables benefit company structures in healthcare. Support state and local policies that remove barriers to housing development. AllCare has identified zoning reform, particularly in rural areas, as critical to addressing Southern Oregon's housing shortage. Healthcare professionals working with AllCare can screen patients for housing instability and connect them with resources. Housing status should be assessed as routinely as blood pressure or medication adherence. Business leaders and insurance representatives interested in how housing investments improve employee health and reduce healthcare costs can study AllCare's model. The innovation isn't in the individual housing projects. Emergency shelters, senior apartments, and teacher housing all exist elsewhere. The innovation is in a healthcare organization recognizing that funding these projects is healthcare work, not charitable activity peripheral to their mission. As Julie Akins reflects on her journey from journalism to mayor to housing director for a healthcare organization, we have to stop leaving people behind, pure and simple. That principle, that healthcare means caring for the whole community's health, not just treating individual illnesses, is what reimagining healthcare looks like. It's messy. It requires working outside traditional healthcare lanes. It demands partnerships with sectors that don't typically interact. It takes patience, as housing development operates on longer timelines than medical interventions. But it works. And increasingly, it's what genuine healthcare innovation looks like. AllCare Health's experience shows that healthcare can operate differently. It can be locally controlled, physician-governed, and community-focused rather than corporatized and profit-driven. This isn't going to solve every healthcare challenge we face. The American healthcare system has deep, complex problems, but ownership structure fundamentally shapes how healthcare gets delivered and who benefits. When physicians who see patients daily are the ones making decisions, when benefit corporation status legally requires considering community impact, when housing directors with lived experience of homelessness shape investments, that's when healthcare starts serving communities instead of shareholders. Thank you for listening. If you want to learn more about AllCare Health, visit allcarehealth.com or contact member services at the number in the show notes. If you want to get involved with Reimagine Healthcare's work, visit our website. And if this episode resonated with you, share it with someone who needs to hear that healthcare can prioritize people over profit.